Welcome to Oncology Morning Commute, recognition of actionable biomarkers in colorectal cancer. Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from CGen. In this first podcast of our three-part series, Dr. John Marshall and Dr. Sunny Kim discuss biomarkers for colorectal cancer, including HER2. Are you aware of the current guideline recommendations for biomarker testing in colorectal cancer? Doctors Marshall and Kim discuss these and more. Information about the faculty and disclosures can be found at morningcommutepodcast.com/CRC1. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Marshall is a professor in the Department of Hematology Oncology at Georgetown University in Washington, D.C. Dr. Kim is an assistant professor of medicine at the University of Colorado in Aurora. I am your host, Candace Hoffman. Dr. Marshall will begin our discussion.
We are so happy to be with you this morning. I guess if you are indeed doing Oncology Morning Commute, but there are no rules. You can listen to this over lunch or over an evening cocktail as well. I'm being joined today by not only a very good friend, but just one of the greats in the treatment of GI cancers, Dr. Sunny Kim. We were pleased to be partners for a while till she ran off and left me for the great state of Colorado. And Sunny, Dr. Kim, thank you so much for joining me as we talk about biomarkers in colorectal cancer.
Thank you for having me. It's great to be talking about biomarkers in colorectal cancer.
Yeah, there's a lot going on in this space. And I think there still is, unlike some cancers where the uptake in biomarker testing has really been quite good, I think in colorectal cancer, we're still kind of lagging behind in terms of having, everybody getting tested for the right things that they need to be testing. And so this is a bit of a moving target. So maybe I get to pick on you first and kind of give me an overview of what you think today's standard of care is. And we're really focused here mostly on metastatic colorectal cancer. So you have a patient with metastatic colorectal cancer. What do you got to know?
Yeah. So I think the big picture is that we have to find the right drug for the right target. This is what we aim for every patient, truly personalized medicine. And the way we do that is with biomarker testing. So at minimum, at this point, with a patient with newly diagnosed stage 4 metastatic colorectal cancer, we recommend that patients get KRAS, NRAS testing, that has implications for drug options, as well as BRAF testing, specifically the V600E mutation, and then HER2 testing, which we can go into in depth a little bit later. Also, if it hasn't already been done, mismatch repair deficiency testing, as well as checking for microsatellite instability. And then less frequently, because it's so rare, there's a fusion protein called NTRK that should also be tested for, because if the fusion is present, there are very good drug options for that patient population. And then we also have been looking at tumor mutational burden. The data here is a little bit more controversial, but if the tumor mutational burden is very high, then there may be a role for immunotherapy. So for me, this is the minimum for patients, because all these are actionable and could potentially improve treatment options for our patients and hopefully their survival.
Yeah, you and I have been doing this a long time. I mean, have you ever found an NTRK, by the way?
I haven't. I'm waiting, though. I haven't found it in any GI cancer yet, but I know it's there and it's a needle in a haystack. And the day I find it, I'll be very happy for that patient.
The one I have found was it's actually kind of a interesting story, and I think is useful to why we should be persistent. It was actually in a second opinion. The patient was a neuroendocrine cancer patient, is a neuroendocrine cancer patient, a physician, and he came to me for a second opinion from a fairly rural hospital in our area. And I said, well, we won't find anything, but let's just do it in case. And it took 3 months for his hospital to release his tissue for this testing. And when we finally got it, I kept I said, forget it. Why am I doing all this extra work for getting this tested? He is my one Willy Wonka golden ticket that I have found over time. And he's been on Intrek drugs for quite some time now. So there's a reason to be persistent.
Wow, that's amazing. And yeah, the fact that it could vary the level of care depending on where you go and, getting second and third opinions. But I'm so glad that you were able to find that in him and give him more options.
I feel lucky. So let's kind of drill down on the testing. You first mentioned KRAS. And originally it was very specific to KRAS, and then we recognized that there were other RAS abnormalities. Then it's BRAF, and the main one there I always think of as V600E, and then HER2. Our site can do these. I know your hospital can do all of these tests, but don't really do, say, fusions, for example, or tumor mutational burden, because we don't do next-gen sequencing on our patients in our hospital. So how are you dealing with this just from a practical perspective? Are you sort of sending out? Do you have all of this in your hospital? What are you telling folks?
Yeah. First, I can talk about, what we do at my institution, and I think it's very similar to what you probably do at your institution. Our lab here can easily do KRAS and RAS testing, do the MMR testing, BRAF, and HER2 testing. But I'm looking for more tissue efficient testing. And I find myself increasingly, sending my tumor samples for next-gen sequencing because you can get everything all at once. I also found that the turnaround times have been pretty acceptable, say about 2 weeks with certain companies. And it's just nice to be able to have all that information. And I find that the depth of information I can also get, say with HER2, since, we're going to be talking about that a little bit more later, HER2 mutations, which it's unclear how we act on that in colorectal cancer, but yeah, I've been able to find those, and that may not be something I can easily do with my lab here. So if I'm in a pinch and I need this testing immediately for whatever reason, I will look to my lab. But if I'm looking to really get a comprehensive look at the tumor, I like next-gen sequencing a lot.
Yeah, I totally agree with you. And I've gone sometimes to, I've got some of these tests back from a local lab. And we'll still go with the broader testing, just so I know in that patient in front of me that I've done all the testing that there needs to be done at the moment, the current standard of care or the current options, because many of the things we'll find in NextGen and others are going to be potential targets either in the next year or two, or certainly in the future. So I kind of want to know, and I also reflect on this, what would I want to do if it was my tumor? I realize we're trying to balance being the shepherds of our healthcare dollar. But on the flip side, one of these tests is getting to the cost of, say, an MRI or a PET scan. And so for what is an acceptable amount of money, you can get a remarkable amount of data. The one struggle I get, one of the main struggles I have with this, is finding the result in my chart. Depends on where it was sent, and is it coming back electronically? Have I gotten it on a fax machine somewhere and somebody loaded it into an EMR? So I often spend time each clinic just making sure I've got the test, and I double check it. I document it in my progress note in the HPI section, what we've got and where we're doing. But do you have any advice to others about how to manage this data once you get it back to make sure it's in front of you?
Yeah, I've seen it done some way. So for us, when the results come back, it automatically gets uploaded into our media tab. So it's accessible. But if it was done, say 2 years ago, you have to look back. So that I agree is probably not the most efficient way. But I've seen some providers just put the relevant mutations and biomarker testing within their note for them to refer to later on. And I find that to be very helpful too, especially if patients are coming to me for second, third opinions. And I can just quickly see that the relevant biomarker testing and then be able to go back and get the actual report.
And, let's kind of shift gears a bit and talk a little bit about different tests, because there's a lot of language around this. And these tests are done differently. We talk about liquid biopsies, ctDNA. Many of the tests we've already mentioned, some are done by immunohistochemistry, some are more gene sequencing tests. And I actually had a patient I saw yesterday in whom I ordered a ctDNA analysis for minimal residual disease from one company and a next-gen sequencing analysis and immunohistochemistry analysis actually from a different company, because I like the different ways that they do these tests. So it's not a one-size-fits-all for every clinical scenario. So maybe starting with a very basic, sort of distinguishing ctDNA for MRD, minimal residual disease, and genetic testing for target discovery.
Yeah. So I think ctDNA or liquid biopsy, as we call them, is a really great option. The big reason is because it's non-invasive. Well, actually, it is invasive. It's just blood draw, but we don't necessarily need to hunt for the archival tumor tissue. And for some patients, it may have already been exhausted with prior testing. And in addition, it may not be feasible to do a new biopsy due to safety reasons, or if the patient is just not happy about another invasive biopsy procedure. We've found increasingly, though, that assessing ctDNA, the concordance rates with tumor biopsies is really getting pretty high, which is great to see. I think some of the earlier studies showed a discrepancy in terms of concordance rates, but it's definitely improved. But at this point, tumor testing is really the gold standard because you can assess for certain types of protein expression that you may not be able to get on a liquid biopsy. So right now, I try to do only liquid biopsies if we still need some kind of genomic testing, if there's no tissue available or new tumor biopsies are not feasible at this point. But going back more to bread and butter, like you were talking about, when we specifically talk about kind of more old school techniques, I'm thinking about like in HER2 testing. Classically, we've done that with immunohistochemistry, where we stain a tumor slide, and a pathologist goes and looks at it and sees how strong that staining pattern is, and the score can go from 0 to 3+. And if we find that the score is intermediate, which we call 2+, then we reflex to something called FISH. And this stands for, fluorescent in situ hybridization. And we can see if that HER2 gene locus is amplified compared to control. And if the number is 2 or above, it's considered FISH positive. This is with the really classic HER2 scoring criteria that has been used in breast cancer and gastric cancer. And for colorectal cancer, that's the eligibility that we've used for one of the major clinical trials that we'll discuss a little bit later. But we find that in NGS testing, we're able to go beyond just the IHC and the FISH. We're able to look at amplifications. We're able to look at HER2 mutations, which I think is a very interesting area of discovery in the future. When we think about cross-cancer talk, I only recently realized that in lung cancer, it's really the HER2 mutations that are important. And that's where, certain drugs have been FDA approved. And I'm really looking forward to seeing what we can do with that in colorectal cancer. Happy to kind of probe your mind too about that field.
Yeah, no, absolutely. I think, I was asked to see a patient just this week where they were kind of resistant to everything. And it made me think, this is going to be a HER2 positive patient. And yet their immunohistochemistry was negative, but on gene sequencing, there was a mutation. So, the question is, do you then consider going after something like that with HER2 targeting? When the sort of phenotype, the clinical phenotype was leaning towards this kind of abnormality. So I do think we have to keep looking deeper to understand what makes these things tick when we have these therapies that can intervene. But where we are today is just as you described it, with the immunohistochemistry, with flipping to FISH and ERB amplifications and mutations do come up when we do the broader profile, and it does provoke us into wanting to try these kind of strategies. So I completely agree with that. I also want to kind of add in that when we talk about liquid biopsies, Most of the time when I use that terminology, I'm thinking about trying to find a RAS mutation or something like that, presence of a genetic marker, a specific genetic marker. And there we have to make sure, you can sometimes find that you don't get a result because the tumor doesn't shed or is not present in high enough quantities in order to detect. And that technology is way cool. And as you say, is getting much better. But, the broader you go with that, then you can't be as deep. And the deeper you go, the less specific you get. And so you'll pick up sensitive stuff, but it may not be tumor. It may be, some marrow abnormality, for example, that the patient has that's unrelated to their original cancer. So we're hoping that technology gets to the place where it can do away with tissue testing. But right now, I totally agree with you that if you can, tissue testing remains the gold standard, using what I think of as liquid samples to look at change over time may become a new standard. But then there's the other technology for minimal residual disease that is really asking a different question. That's not which mutations are there, it's if any cancer mutations are there, a yes, no, with a quantification that goes along with that. And that's a technology that's really been led by the colon cancer world of looking for minimal residual disease, but that's different than what we're talking about. That's sort of like a very fancy CEA or a higher level blood test to say yes or no, there's still cancer around, and is it better? So I just want our listeners to make sure they understand that our patients are hearing all of this language. We throw it around in different settings. And so we want to make sure as we talk about any sort of testing technology that we're at least in sync with what we're trying to figure out. And also know that different, as you say, companies and labs do these tests differently. When we send a patient for a CAT scan or an MRI, for the most part, we know we're getting very similar quality, very similar return on those results. If they were done well, if they were done on a modern machine, if they were done with a proper contrast, the one done at University of Colorado is going to look a lot like the one done here at Georgetown in terms of quality. But when we're looking at molecular testing, they're not all done the same way. And there can be different sensitivities and different results. Probably not fundamentally for most of the markers we're talking about, but when you get to some of the more subtle things, there can be differences in those technologies. While we're talking about that, though, are you finding that, like in lung cancer and in breast cancer, where they repeat tests and find patterns of resistance and the like, and maybe particular to say something like RAS or HER2, are you finding that there's changes over time and therefore we should be repeating tests like they do in those other diseases?
Yeah, I think that's where the field is definitely heading towards. I would love to get these, ctDNA tests back in real time, but unfortunately, the reality is sometimes I get them weeks later. It's hard to act on them immediately. But we know that with interrogating, doing genomic testing through assessing, cell-free DNA, these allelic fractions, they can change over time, and sometimes, that RAS clone or HER2 clone may start to reemerge again, and targeting it with a targeted drug is something that should be very realistic and probably would help the patient. I know there was a recent study presented, I think last year, kind of using ctDNA to determine whether introducing targeted drugs again in colorectal cancer is beneficial. And I think that's where the field is going right now. But until I think the technology is really able to kind of catch up to the urgency in which we need it, I'm not sure if we're ready for that yet. What are your thoughts?
Well, I'll give you an example of a case I saw this week. It's been a busy week where there's a patient that I saw in Second Opinion where their doc had done a blood test, a ctDNA liquid biopsy blood test and found a BRCA mutation of unknown significance. And I think was distracted by that, and in fact started a colon cancer patient on a PARP inhibitor based on that, and was able to get that approved and the like. And it's not clear to me whether that's the right move, but I do worry in a patient like this. Okay, now do I have to do germline? Is this really something real? When you find some of these unusual, less well-defined targets, how we tend to want to go after them in the hopes of finding remarkable outcomes. So I'm a big re-challenger. I think as we talk about HER2, I think one of our critical questions is going to be, do we need to retest somebody before we, re-challenge them with a second agent, for example, like they do in breast cancer? But I think there's still a lot for us to learn. Let's kind of go to one last area before moving on. And, I think about colon cancer now much differently than I did even 3-5 years ago, where then it was sort of a one size fits all, maybe minor modifications in thinking, to now where, again, kind of like breast cancer, if you're triple negative or ER positive or HER2 positive, you think completely differently about that patient. Well, we're getting there in colorectal cancer. And so if there's a RAS mutation, I know that takes some pieces off the board. Depending on some patients, it might put a piece back on the board. If you have a certain, like a G12C mutation, I look at BRAF, and I immediately think of, okay, this is a patient where I've got a sort of first line, second line approach to patients like that might be different than other patients. I've got an all wild type. I want to double check my HER2s are negative to make sure they're all wild type. And then I'm thinking about different strategies in that patient. Even left and right, I began thinking a bit differently. So, but I'm not seeing that uptake in the community as much, where they're really thinking and classifying patients according to their molecular subtype. What's your take on all of that?
Yeah, I think it's really an emerging field in colorectal cancer. There's been more data in BRAF mutations, ongoing studies adding immunotherapy to, the targeted agents. And then the HER2 field has just really exploded. So I think we need to publicize the pie and the sections of the pie. I think the lung cancer has done a great job at doing this. Just really showing providers pictorially that all colon cancers are not the same. And depending on what the molecular features are, we can go down very different treatment paths.
Yeah, I totally agree. Well, we're going to get into the weeds on HER2 in specific. And I think a lot of our listeners are like, what, HER2 and colon cancer? That's never seen one. And I'll bet you it's because you've never looked. And increasingly, the more we look, the more we are finding that it is not common. Don't hear me wrong. It's not common, but we're going to spend some time focusing on that. But as you point out, that's only one of the wedges of the pie. And so in essence, every patient with colon cancer fits into one of these categories. And with that definition, you now have pathways that are defined, or increasingly being defined, by both standard therapies as well as targeted therapies that will flow through all of this. So listen, thank you for joining me for this morning commute. And I think this has been a great overview of where we are on precision medicine and colorectal cancer, with an emphasis on the different tests that we have out there and how we're going to apply these tests into therapeutic options.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/CRC1. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.